Welcome everyone to Module 7. We are just about at the halfway point. Today we have a guest speaker, Dr. Herbert Chase, whom you can see. After Dr. Chase speaks, then we'll come back together and we'll do a little bit of class business. I'd like to highlight some points for you from this week's readings that weren't the primary thrust of the readings, but things that I'd like you to take note of. And then we will go over the submission of the abstract for the final paper that's coming up on March 6th. So we'll go over the dates. And also I'm going to offer you some additional topics, just a variety of additional topics for you to think through, as well as what you may already be doing, which is surveying what's coming up in the future weeks. So, excuse me just a second while I move around on my computer. I'd like to introduce Dr. Herbert Chase. So Dr. Chase is currently a professor of clinical medicine in biomedical informatics, and he's involved in many research projects. They explore the development and the integration, potential integration, of artificial intelligence into the electronic medical record and to improve clinical medical practice. I hope that Dr. Chase will tell us a little bit about his journey, trained originally as a clinician and having added bioinformatics to his portfolio in a quite serious way. So his projects include developing automated methods to detect chronic kidney disease in its earliest stages, which would be good medicine, good for patients, and good for the healthcare budget. Using machine learning to predict the future natural history, the natural course of chronic illnesses, implementing strategies for pharmacovigilance, operating through the electronic health record, and the creation of a patient record summary in the electronic health record. And of course, we need best quality data in electronic health records so that we have good quality big data to apply our fantastic computational skills and very sophisticated forms of machine learning to for all our benefit. And with that, I'd like to turn it over to Dr. Chase.
Well, thank you very much. I'm delighted to have this as my first Zoom experience. I hope I have many more opportunities through different classes. I'll give you a brief summary of my career. I've been here at Columbia for over 40 years. I started out and still am a card-carrying kidney doctor. I went through the training of kidney disease, and then I spent the 80s working in my lab trying to figure out how the kidney worked, how it handled salt every day that we eat salt. Then in the 90s, I directed my attention to education here and developed and ran the huge basic science course for the first-year medical and dental students, 300-hour course where we had 100 faculty members. It was sort of the basis of understanding the biology of health and disease. Then in 2000, I left for 6 years to be the Dean of Medical Education at Yale. And in 2006, I thought I missed scholarship and I missed research and I hated administration. And I thought, well, what am I going to do next? And having spent my career teaching medical and dental students how to be better doctors and dentists, I was curious to know if there are ways of sort of measuring how good a physician is. I had no idea of how one would approach that, because then we could ask, does this intervention make the student a better doctor if we had a way to measure how good they were? And I started thinking about prescribing medication. And I wondered, is it a measure of a physician's competence if they prescribe drugs that have no value, that have no efficacy, and all they have is side effects? So at that point, I wondered, how am I going to study that? And then somebody at Yale said, well, why don't you go talk to the informatics team? They've got a record of every medicine that a patient has ever taken and who prescribed it. And at that point, I was completely hooked with the idea of using computation and biomedical informatics to both derive new knowledge from patient data as well as monitor healthcare actions and activities. So now, 15 years later, I'm actually still studying drug prescribing. We have a paper that we're working on where we've been looking at the drugs that patients are taking that interfere with each other. So that's a little bit more long-winded than I intended to be. And just as an aside, I spend half my time overseeing the educational programs for the department, do a lot of teaching of medical and dental students during all 4 years to try to introduce them to data science and what the power of artificial intelligence is and what they expect in the future. I thought that I'd say a few words about my title. I spend a lot of time thinking about titles, and I change my title as I go through the working of a talk because it reflects my emerging understanding of what the sort of higher level issues are. And I realized that now that I've thought deeply about the pluses and minuses, there's obviously a huge upside to artificial intelligence in healthcare, but there is an equally possibly bigger downside. And it's not because AI is going to take the jobs of doctors, which I'll mention later on in my talks about radiology, but there are some serious problems with AI, and I'm going to talk about them in the second half of my talk. I'm going to focus on the ethical issues as well, and so we'll talk a little bit about what's working for AI and then what's not working for AI and what we should be worried about. Let me just, let's see. All right, how do I advance? Here we go. I have to do it manually, God forbid. Just a couple of disclosures. I consult with startups in the healthcare space. I taught Watson, along with my medical students, how to be a good doctor in the early part of the 2010 to 13. This is when IBM had just beaten Jeopardy contestants and now wanted to have a medical version of Watson. I was on their advisory board, but as of now, I have no contract or actually any contact with IBM, and that will be apparent when I start talking about some of the missteps that they've made over the years. I think it's always helpful to look at today's goals. We have 3 learning objectives. First, after this lecture, you should be able to describe the need to integrate AI into medical practice. I mean, how well are we doing as clinicians, and how much better could we do if we had AI? I think you should be able to provide some examples of successful use. I think you should be able to discuss the shortcomings of AI, which we'll go into some detail. And then I'll ask, or I think at the end of this talk, you should be able to have a discussion, at least. You may not be able to answer the question, as whether AI in its current form can be trusted. And we'll talk a little bit about trust later on in this talk. First, a little overview of why we need AI in medicine. And I just, as an aside, in the 70s when I was training, Medline or PubMed first came out, and we were taking care of our patients, and we would have questions that we wanted to answer, and we'd go to the librarian, and they'd disappear for a week, and they come back with a PubMed list of articles that were helpful, and we'd say to each other, reminder, this is 40 years ago, this is incredible. A computer is going to revolutionize the practice of medicine. Well, 40 years later, we're still not there yet, whereas in every other industry on the planet, technology has revolutionized their business model. You can't go into Home Depot without thinking about all the tech that's behind the scenes that's keeping track of everything, or Amazon wouldn't exist. Medicine, we are decades behind, in part because of the difficulty of making sense of patient data as well as the costs. So we need AI, and here are some compelling statistics. How are we doing? I like to always report on our report card. Well, we're not doing very well. We misdiagnose. A diagnostic error represents 20 to 30% of medical error. We often misdiagnose. We don't get the diagnosis right away. There's some diseases like endometriosis, which you might have read about in the paper recently. It can be years before a woman is diagnosed correctly with endometriosis. We're asking, why can't that be diagnosed earlier with AI? And we misdiagnose it. So we're not doing very well, not because we're not trying hard, just because it's beyond human capacity. We don't follow guidelines. Now, not because we're lazy or we don't believe in them, it's just you can't find them in a timely manner. You can't sit in front of a patient and say, gee, I wonder what the guidelines are for chronic kidney disease. Even, I think more, you'll never go to a doctor after you hear this talk. Looking up answers to questions. One of the studies I conducted a couple of years ago, but it's well known in the literature, most of the questions that arise during a clinical encounter, like when you go see your doctor, those questions are unanswered. And they make a difference. I mean, it would make a difference to answer those questions. Again, because there's not enough time and because of the infinitude of medical information. Another realm, which I won't talk much about today, is the fact that we, and this is a use of the word bias in a slightly different context than you have been thinking about it. Humans have internal biases which they can't avoid. You can't avoid a bias, and it does alter the way you think about things. And it's been shown now for a couple decades that doctors routinely approach decision-making, bringing to the decision unconscious biases, which they're obviously by definition not aware of, which influence decision-making. And it contributes to medical error. There's no question about it, and there have been dozens of papers on this. If you haven't had a chance to read Thinking Fast and Slow by Dan Kahneman, he basically won the Nobel Prize, I guess a decade ago or more, because he was able to explain why investors consistently do the wrong thing. Whatever the choice is in investing your money, they do the opposite of what they're supposed to do. And it's largely because of these biases that percolate in the back of our brains. Jerry Grubman, who's a brilliant scientist at Harvard, wrote an entire book on all the mistakes he made because of his biases. So theoretically, AI is not going to be biased, and we'll talk more about that later. But this is we as humans can't avoid having biased thinking, and we're hoping that AI can help us in that regard. So just finally, medical error, you've probably seen this before, it's the third leading cause of death in the US. I mean, if you tell people this, their jaws drop. There's cancer, there's heart disease, there's medical error. And for those of us in the business, this makes total sense. We see medication errors, we see people getting the wrong limb removed, we see all sorts of problems that hopefully will be solved by technology, not necessarily AI. But down the road, we're going to need to do something important. So our report card, as far as I'm concerned, is not great. It's a C-, and we need help. And again, it's not because we're not motivated to do better, it's just that it's beyond human abilities, and that's where computers come in. So AI has a couple roles in medicine. First, it can deliver information to us at the bedside, vetted and appropriate. So sort of the ideal situation is that you ask Siri, how to treat X, Y, and Z, and AI goes through the literature, it figures out what the better routes or efficacy of drugs are and what procedures you should use, and it delivers it in a timely manner. That is to say, when you're sitting there with your patient, you can't, if it's delayed, like come back in an hour, that's not going to work. So it can deliver knowledge. And it can also, I'm going to talk a lot about decision making. It can analyze thousands of pieces of data from a single patient and determine the optimal approach. This is, to this day, I'll mention it later, I don't know how humans make medical decisions, physicians, because there's always so much data. And what we do is we're reductionists. We just ignore whole aspects of the patient's case because we can't fit it into an analysis. This should be remedied by implementing AI. So before proceeding with the pluses and minuses of AI, I thought I'd just visit the clinical encounter. Any of you have ever been to a doctor, which is probably all of you, or you've brought your loved one or your parents to a doctor's office, the drill is the same, for every encounter. The patient has an interview with the doctor or the clinician, it gives a history, the clinician performs a physical, there's a working diagnosis, there's testing, test interpretation, and then at some point down the road, there's some agreement as to what the therapy should be. This involves some serious clinical skills, which is one of the other things I teach here at the medical center. Diagnostic reasoning, how do I go about making or coming to the right diagnosis, clinical decision analysis, how do we come up with the best decision? And then both of those skills are somewhat plagued by cognitive errors that I've mentioned before. And we also teach that to the medical students. This will interfere with sort of accurate diagnosis and decision analysis. So a computer can actually help us on all those fronts. It can help us make a diagnosis. It can also help us come up with evidence-based therapy and find the right decision for that patient. And it can also embark on a bias-free approach. That is to say, ignore all the little biases that plague the human mind and just, try to make an analysis as strictly objective and scientific as possible. So I also want to make a distinction between a computer application that is not AI and one that is AI. We have, and you might have heard this term already, I only bring it up just to make the distinction, that the electronic health record is already embedded in it are many decision support tools. The machine facilitates and completes tasks that we as humans would be able to accomplish, but it does so in a more efficient manner. So consider drug-drug interactions. I'm going to prescribe a drug to my patient, they're already taking a drug, and I ask myself, are those drugs going to interact? I could easily go to a table and look that up. But a computer can do it 100 times faster and it probably more accurately. And it's not that I can't do it, and that's not AI as far as I'm concerned. That's just a computer doing a chore for me faster and better. AI, I think by definition, means that the algorithm or the machine is actually coming up with a new piece of information, or it's accomplishing a task that's not accomplishable by a human. As I mentioned, we're going to talk about, again, decision analysis. There are so many moving parts that a human is incapable of optimizing a decision, whereas an algorithm could be if it's good enough. Certainly that applies to diagnostic tools as well. The computer can analyze hundreds of attributes that improve diagnosis. And again, a physician is not able. So I'd like to make this distinction between what I can do, but I'd rather have a computer do it, and what I can't do, and I need a computer to do it. All right, so let's just power through some success stories. Diagnosis, you may have heard about these already. This is a machine algorithm, deep learning, and it basically was trained on patients with diabetic eye disease. And it's so good that it will probably put a whole bunch of ophthalmologists out of business. It basically, what it does is it screens patients with diabetes, and it can say whether or not the patient needs to go see an eye doctor. It's trained on thousands of pictures, just the way Google trained the machine to recognize a cat after training on hundreds of thousands of cat pictures. This algorithm can identify patients who need to be referred. It's a tremendous breakthrough. I believe it's being employed at several different institutions. The statistics are outstanding. I'm going to talk more about the developers of AI have to be sure that they have output statistics to prove that something, whatever they developed is actually better than the thing that already exists. So that's a real success. This one caught my attention. There are a lot of numbers here, so don't look at them. But basically, this is a study from China, and it might be USC, or I'm not sure. I just want to point out that AI in medicine has progressed to the point that now the articles are appearing in Nature Medicine. This is one of the premier medical journals. It's not that these are being, submitted to and published in a traditional AI or informatics journal. It is the quality of the AI has gotten to the point that it is now sort of medically important. So this is a machine that diagnoses pediatric diseases in the emergency room, and the machine was incredibly good. It trained on, as you've heard about training, it's trained on thousands of cases, and it's incredibly good. It's better than the group that is in the red box. These are trainees, that the machine actually was more accurate than the trainees, but not as accurate as the blue group, which are the senior physicians. So first, the fact that the machine is almost as good as the senior physicians in and of itself is a tremendous victory. The other point is, not unexpectedly, trainees don't know as much as senior physicians, and the AI here, the classifier for the decision support, or in this case, algorithm, diagnostic algorithm, that could be of value to the trainees. So this, I thought, was a tremendous success. I'm not sure if it's being implemented anywhere, but certainly it should be tested. This is another a brief victory. It's cancer screening with three-dimensional learning. They trained on thousands of chest x-rays, as you can imagine, and the predictive value false positives, false negatives, true positives, true negatives, was better than 6 radiologists. The machine had fewer false positives and fewer false negatives. So, the students who were interested in radiology, they're concerned because there's going to be a whole level of radiologists that don't need to do the screening. But the machine's role here is to say, you got to look especially at these cases because we think there's a possibility of cancer, and the rest of these has passed muster, and there's probably a low probability of cancer. So this is another victory I see for AI.
Dr. Chase,
Yes.
I'm wondering, in the last example, would that be senior physicians that did not do as well as the computer versus the trainee physicians?
I don't know.
Okay, sorry.
I don't know. It's a good question. I should look that up. I will.
Thank you.
So the conclusions, I think right now, machines are better at diagnosis than humans when the disease is established. Now, I think it's important to remind ourselves that machines are only focused on digital aspects of a patient, but as we know, patients are analog. There's all sorts of stuff in between. So the machine is going to be trained on what can be digitized, and it's not going to be able to use sort of the in-between, and that is often the case when a patient doesn't fully manifest the disease. They're on their way to manifesting multiple sclerosis or lupus, and they're sort of not there yet. That's where humans may still have the edge, but we'll think about that. What other success stories are there? Just a couple of short ones. Prediction is a major concern to patients. My creatinine is 4, or my heart cholesterol is X, Y, and Z. What does that mean for my future? And there's a tremendous amount of focus on prediction, especially since, for example, the Medicaid and Medicare services have demanded that hospitals come up with predictive models to figure out who's going to be readmitted and who isn't. Because if a patient is readmitted too soon, then Medicare, CMS is not going to pay for reimbursement, which of course is going to bankrupt all the hospitals. So there's a tremendous focus on prediction. I give you one example, a local example. This is the classic Framingham example where you can go onto the web now and plug in your numbers, age, blood pressure, et cetera. It will give you a probability of having a heart attack in the next 10 years, or I forgot what it was. But there clearly have to be more than 7 attributes that are predictive. And so just as an example, and it's one of my colleagues did, this is why I'm pointing it out, Noemi El Haddad, she looked at 300,000 patients here with and without coronary heart disease. They looked at everything, medication orders, diagnostic codes, vital signs, et cetera, and they came up with a predictive model which also identified new attributes. I think that one of the great things about data mining is that it will identify attributes that are predictive that were not necessarily considered by humans. They may be indirectly predictive or not. My zip code might be predictive, and that doesn't make any sense physiologically, but it might be predictive because of the care people are getting in their local zip code. Their church group is making sure their blood pressure is well controlled, and that zip code conceivably could be predictive of a bad coronary outcome. So the machine will identify new predictive attributes. And Noemi's machine is better than Framingham. It's not a lot better, but it's statistically better. And it just gives you an idea that machines are capable of developing prediction models that are far superior to the ones we have. In fact, if you look at every prediction model that the clinicians use, it's based on 3 or 4 entries. I'm looking for being admitted to the unit, the intensive care unit, having a gastrointestinal bleed. There's a whole generation of predictive modeling that is about to unfold. And this is, I think, another victory. The management of sepsis is my other example. And 10 years ago, we were using computers to monitor sepsis. I mean, here's a classic intensive care unit. You can see 2 residents sitting at the desk, stupefied by all the data that's coming in. And the machine there was used to monitor what's going on. You can see an electrocardiogram in the left-hand monitor, but there was no decision analysis here. The machine wasn't actually thinking. It was just telling everybody, what data have I collected, and it might have alerts, the blood pressure is too high or the blood too low, et cetera. That was a generation ago, meaning 5 years ago. Now we have a predictive modeling algorithm, probably more than one, that actually can, by reading just look at all the things that are hanging up in the background here and all the machines and things that are being measured. Now the algorithm reads all that and helps the physician decide what to do next. Sepsis is life-threatening, and there often has to be a speedy intervention. So this was recently, again, in Nature Medicine, which has very rigorous reviewers. Here, the machine trained on thousands of pieces of data from the intensive care unit. And they basically, I think, convincingly demonstrated that the machine AI clinician selected treatment, picked the next treatment based on the sophisticated decision analysis, on average, was reliably higher than human clinicians. And I think younger clinicians, this is a no-brainer. Of course you can't master all that information. But the older clinicians of my generation, I think, are still trying to hold on to the, what we used to do, which was make a guess. Oh dear, make a guess. You'll hear my email buzzing every now and then. Sorry about that. Make a guess as to what we think we should do next, when in fact the machine ends up being better, because it's monitoring all these things that a human can't pay attention to. So I think that is a tremendous step forward. Lastly, antihypertensive, and I show you this example merely to convey how complicated decisions are when you're only trying to decide between one of two drugs. Patient comes to me, has high blood pressure, and I am trying to decide, does the patient need drug 1 or drug 2? Well, that simple decision involves 4 different probabilities. Is the drug effective or not? Are there adverse events associated with drug A or not? And 8 different possible outcomes. So already it's beyond human computation. Then we have the problem of all the other drugs the patient's taking. So it's exponentially more complicated. And a human, it happens all the time. Someone's going to come to my clinic and I'm going to have to decide between 2 drugs. I'm going to have to make that decision in a patient who's taking all those other drugs. This happens to be a bag of my mother-in-law's drugs. She gave me HIPAA permission to show her drugs. She's no longer with us, but I always like showing her bag of drugs. How can a human is not capable of that? We're going to need a computer to make that decision, and they don't exist right now. I'm trying to get one of the students to do it, but no luck. So conclusions, machines to some extent are better, but they will be soon. And I imagine the next 5 years is going to be breakthrough, and there'll just be an explosion of very specific decision analysis algorithms. It has to be very specific. All right, let's flip over and ask, we have these successes. Now, what about trust? How much, I'm a typical clinician, do I trust AI, forgetting about my legacy to the old days, the bad old days when we made decisions without machines. But let's just talk about trust and talk about the ethics of the industry. The fundamental premise in the clinician-patient relationship is that there's trust. That patient's looking at the doctor, and that patient is going to tell the doctor stories and things about him that he would never, ever tell anybody else. And there is a trust that that doctor is going to be mindful of all the private conversations, guarantee security, be discreet, and the trust can only be based on a conversation where it's clear that the doctor is trustworthy. And for many years, I don't know, actually, I'm sure Stephanie knows this, I don't know the history of the 4 underpinnings of medical ethics, but through the medical curriculum, we focus on the 4 basic principles of ethical behavior in medicine. It's non-malfeasance, that's an easy one, do no harm. I mean, Hippocrates came up with that. Justice, we as clinicians believe that all patients benefit regardless of their social status and means. That's why we get so upset when insurance won't cover a benefit that we know the patient would benefit from. Respect for autonomy. The patient has the final say. Our job is to inform the patient, and we're going to use AI to help inform us to inform the patient. But at the end of the day, it's the patient's choice. And lastly, beneficence. We have to think that what we're doing is a benefit to the patients. We have a duty to benefit the patient. So this is the basis of the sort of moral code or the ethical code in the practice of medicine. In all 4 years of medical and dental school, we drill this through the students' head. We have conferences on it. We discuss it on rounds. It's very important. We're a profession. We monitor ourselves and we hold ourselves up to high standards. But now we have another actor. We've got the computer in the room. And that is complicating the situation. The patient may be thinking, well, do I trust the computer? And then the patient may say, well, my doctor is going to make that decision. The clinician is going to make the decision. And the clinician is thinking, do I trust that computer? And what are the issues that I need to be worried about? So first, I'd like to start out with, do we trust the machine? Forgetting about the ethical issues. How good is the machine? I just showed you the success stories. But for that doctor to look at that laptop and say, I trust that. I often, when I give this talk to the medical students, I hold up my phone and I say, the phone's telling me to do something. Got a human sitting across from me. How do I know whether or not to trust that? It's a very difficult question. And I have no answers for that, but we're going to discuss it anyway. So I want to just talk about errors, typical errors. And, if Google Maps sends me through farmland in Italy, where there's no road ultimately but that was the shortest distance to where I want to go, it's an error in my book. But all right, so big deal. Nobody got hurt. Well, my wife was mad at me, but nobody got hurt. So I thought there are errors in the apps that we use on a daily basis. I thought I'd just point out 2 of them, which I found comical. Doximity is a website where it tries to link clinicians with each other. I published a paper years ago on clinical information needs, and down here are my colleagues, Dave Kaufman, Steve Johnson, and Anita. And so I get an email from Doximity saying, are these my co-authors? Are these my colleagues? And Stephen Johnson, although he has the same name as Stephen Johnson, is an DO, osteopath, in Athens, I guess, Georgia, where Steve Johnson is a scientist and a professor at Cornell. Dave Kaufman is not an infectious disease person. He's actually an informaticist down south. And Maya Rao appears twice. She apparently has an identical twin that she was unaware of, one of whom is a psychologist. Maya Rao is a nephrologist here. My point here is that this was rife with mistakes. And I thought to myself, how hard is it to do that? Well, for those of you who have programmed, it's actually pretty hard avoiding those mistakes. But my point here is that nobody got hurt by this. I just laughed it off. But that was, it's emblematic of the problems we have in computer science. This was the second one I thought, this one I really got a kick out of. I get an email from LinkedIn saying, do you know Herbert Chase, Chun-Hua Wang, and Elides Reyes? These are my colleagues here in the department. And the email was sent to me, Herbert Chase. So it says, dear Herbert, staying in touch with valuable contacts can help you in your career. Quickly connect to some people we think you know, Herbert Chase. Well, that created this profound existential crisis in me. I thought, is the machine telling me that I really don't know Herbert Chase? And I started thinking about it. It was absurd. Once again, this should be easy, but it's a mistake. Well, what about if the mistake's in the medical space? So first, I say that any AI developed in healthcare is only as good as the data it was trained on. And healthcare data is well known. It's legendarily inaccurate. In one paragraph that my colleague found in a report in an electronic health record, in that same paragraph on one patient, it literally said, at the beginning of the paragraph, a 34-year-old man, at the end of the paragraph, it said a 27-year-old woman. ICD codes, which is how we code diseases and signs and symptoms, are notoriously inaccurate. They can be inaccurate up to the point of 50%. That's what a machine trains on. It trains on the data that's buried in those codes. And right now, the data is unacceptably inaccurate. A student of mine did a study on pancreatitis, and it ended up only a third of the patients who we thought had pancreatitis actually had pancreatitis. At that point, we were worried we'd go to Medicare jail because the hospital billed for pancreatitis. We have an inadequate and inappropriate training set. So we just chose the wrong training set to use to train. And this is especially important and does lead to some of the biases that I'm sure you've already heard about. Yeah, I'm sure you've already seen this title before, the racial bias that appeared in an algorithm used to manage health. It's still being worked out as exactly what was mislabeled there, how what part of the data actually gave rise to the faulty predictions by the algorithm. The good news is that serious computer scientists are working on this, and there was some intervention before it could harm the patients. This one you probably also heard, New York Times, the face recognition accuracy. This algorithm was really good at identifying white men, not surprisingly, because it trained on white men, but it was poor at identifying patients, people of color, and poor at identifying women and identifying Asians. So there was automatically, again, you're training on an unrepresentative sample, it's out there, and there needs to be some kind of watch group, whatever the watchdog group. The other point I want to make is there is not just one AI. There's one algorithm. I mean, there are dozens of algorithms, absolutely dozens. And so, of course, it ends up that some are better than others. So I used to show this slide as a victory for prediction, and I've completely turned around and put into my what's wrong with AI box. Here's a paper that was published in PLOS One. Can a machine learning paradigm, whatever, algorithm, improve cardiovascular risk prediction? And I've already shown you Noemi's machine to predict cardiovascular risk. So their conclusion was machine learning significantly improves accuracy of cardiovascular risk prediction compared to available calculators. Well, so they thought. So here's their data. They've got it divided in two sides. They've got the American Heart Association, like the Framingham. You put in your smoking and cholesterol, et cetera, et cetera. And here are the major attributes that build the model. And there are 4 different machine learning algorithms. And they differ. Now diabetes for 100 years has been known to be a risk factor for coronary heart disease. That is a given. Well, only 2 of the algorithms actually found diabetes as predictive. Hemoglobin A1C is a proxy for diabetes. And oddly, chronic kidney disease, which we do know, again, for at least 2 decades, is a predictor or a cause of chronic heart disease. It is not included in the Framingham study, which it should be. And it was found to be an important attribute, a predictive attribute in 2 of these algorithms, but not in the other 2 that found diabetes. So my only point of showing you this is that it does depend on what the algorithm is to build the machine. And some are clearly better than others. Actually, people in our department who are at the cutting edge, so to speak, of research are constantly looking for better algorithms. And that's a...
Dr. Chase, I'm just going to interrupt you. We have a question from one of our students about electronic health records.
Great, thank you.
Carla, would you like to speak up?
Sure. Hi, Professor Chase. It was a bit more of a comment or an observation, but building on what you were saying about the ICD codes and the diagnoses codes, that often the intent and the use of those codes is for billing purposes, and often what they think will be reimbursed. So questioning around the accuracy of then using those and appreciating, I think Stephanie also commented, it's a very US-centric approach to think that way, but some of the deficiencies in the data set in that regard, and curious if you had any reflections on that or observations.
No, you're absolutely right. It's a billing code. And there are additional ways to get better data. One of them is natural language processing, which we've used a lot here, where you actually go through the clinical note and pick up some of the nuances of the patient's condition and then map it to a terminology, like SNOMED or ICD code. So you're absolutely right that it is so ungranular and at times non-specific that in and of itself is not a good source of building a machine. So natural language processing, I think some of the mapping is better now with SNOMED, but you're right. It's at its worst, it's rudimentary. There is a group of scientists across the world with, engaging in what they call phenotyping, which is, can the machine figure out who's got multiple sclerosis? Well, ICD code would be helpful, obviously, but maybe there are signs and symptoms in the chart that we get from natural language processing, so that would be helpful. And then maybe there's some other, maybe referrals are helpful to identify what we call the phenotype, someone who looks like they have multiple sclerosis. So the phenotyping space has expanded dramatically, and we're doing some of that here. So I think down the road, we'll have more accurate data set to train on, but we're not there yet. Good question. By the way, I'm a teacher. I'll talk nonstop. You have to interrupt me, and I welcome it. I think this might be my last example. This was really interesting. I was talking yesterday to a woman who is involved in AI development. A study was done to see if you could come up with a algorithm or a visual tool to identify melanoma, which, as you know, is a deadly cancer. And there are tools out there. You take a picture, the machine says it could be a melanoma, couldn't be melanoma. And what they actually did is they showed that the machine algorithm that was developed after training on melanoma would identify patients with melanoma, even though the melanoma had been erased from the picture. Oh, hello, sorry. So you see here that this is the picture without, without being photoshopped, and then they actually got rid of the melanoma and then asked the machine to classify it. And the machine basically said, well, this is melanoma, using information that had nothing to do with the patient's illness. I mean, this is their quote. Our results show that models can correctly classify skin lesion images without clinically meaningful information. So you could, theoretically, people train a machine to recognize melanoma when in fact, without realizing it, the machine is not recognizing melanoma because of the melanoma, it's recognizing what they think is melanoma based on these other cues, and maybe the accuracy is much lower than they think. So these are some of the problems. I just had to throw this in since I just read about this yesterday. This was a recent study by, and you can see what the collaborations are here. Rich Kruana is at Microsoft, Noemi's here in our department. Mark Strom is here at NYP. They basically tried to build a predictive model from dying from pneumonia. And the machine concluded that the model found a similar pattern as to previously, that having asthma lowers the risk of dying from pneumonia. Now, we know that's not true. I mean, people who have asthma are higher risk of a fatal encounter with pneumonia. And the machine said the opposite. Now, you can reverse engineer, and you can say, well, all right, let's see if we can understand that. Maybe it's because people with asthma go immediately to the intensive care unit, where the other people without asthma end up in the emergency room. There are all sorts of explanations, but it shows how tenuous the conclusions of a machine learning model can be. And it's, I think, problematic. And again, the proof is whether or not it has valid predictive value. So my conclusion, this maybe is a minority view, is clinicians and patients trust the machine? I don't think so. They're skeptical. I think the older generation is skeptical for the reasons I just stated. I'm not sure about the younger generation. They may be less skeptical. Their use of handheld devices where you can find a parking space in front of a kosher vegan deli, and if the machine makes a mistake, big deal. They may be more trusting, and I don't know that for a fact, but I know that people are studying this. So at this point, we haven't gotten to the real ethical issue, but right now I think it's fair to say that there's not a lot of trust of the machine, and nor should there be. But I think I'd like to raise a different issue, or one at a higher level, and ask, do we trust the developers and implementers? See, this is different from, do we trust the algorithm? The algorithm could be perfect, but do we trust the people who are developing the algorithm and the people who are implementing the algorithm? Now, I know I run the risk of sounding, unduly paranoid, but I've been in the business a long time. I've suffered through a lot of heartache over trusting pharma, and I think the same may be true of AI. So I'd like to focus a little bit on what we think about the developers and implementers. I think it's worth revisiting the pillars of ethical behavior, because we can hold the developers to the same standards. Do no harm, all patients benefit, the patient has the final say, and whatever you're developing should benefit the patient. And I just posed the question, is that true? Are they held to that standard? Do they have a code of ethics, the people who develop the software that we hope to use? Are they exposed to a professionalism curriculum? I mentioned we have a 4-year curriculum here. The answer is no. I mean, our MD PhD program, where we have physicians that have a year-long course on ethics, the same is not true of a PhD student in a biomedical informatics course, PhD program. So let's just look at some of the possibilities here. What about non-malfeasance? That's a pillar of ethical practice in medicine. Well, what about what AI and how that may result in an unintended consequence? So this is not strictly AI. This focuses mainly on the implementer. Here's a report from Penn. This is about 10 years ago. They implemented a new computerized physician ordering system. It sounded like a great idea. Everything was ordered electronically. Certainly, you could have drug-drug interaction prompts. You could check to see if the patient was allergic. There were a lot of good reasons why this should be implemented. It was implemented without adequate testing beforehand. This is the key here. So what happened was that in the prior model was a nurse would be on a helicopter with an infant or a pediatric patient going to the intensive care unit. The nurse, as the helicopter is landing on the roof of the hospital, the nurse would say to the nurses in the intensive care unit, please draw up a syringe of this medicine and that medicine and this medicine. And as soon as the helicopter landed, they'd rush the child to the intensive care unit and immediately give them the medicine. The new system, the patient's parents had to register the patient. So the helicopter landed, the patient parents had to go in to the intensive care unit, sit at a desk with a unit clerk, register the patient. Not until then could the medicine be ordered electronically, causing a delay of about an hour. And 52 children, it was estimated, and this was published by Penn. I mean, they took a lot of courage. 52 children died as a result of the implementation. Tragic, but somebody implemented that. And this whole concept of do no harm, I'm not sure that's built into the people who are overseeing the development and the implementation. Penn had another disaster where they implemented the same system and they ended up delaying 4 patients who needed immediate drug therapy. So there are unintended consequences that I think highlight the possibility that something you're doing is going to actually cause more harm than more good. One other example of what I would call malfeasance, or perhaps non-malfeasance, is promising more than can be delivered. Certainly, this is a problem.
Dr. Chase, I'm actually going to interrupt you before you go on.
Oh yeah, please.
Sid, would you like to just repeat your comment from the chat and perhaps amplify just slightly?
Yes, let me unmute myself. Yes, you really are giving a wonderful talk, and it's just amazing. I just feel that with the last example you just gave about the 52 children dying, it's just terrible and very unfortunate, for sure. But I think that this kind of thing happened because the requirements were wrong. And if you don't, whenever you do anything, if your requirements are wrong, then these kind of things are likely to happen. So the most important part is to have a right kind of process, a right kind of requirement, which are being implemented in some fashion. It has nothing to do with implementer now. I really believe that. And I come from software world, and I've seen examples after examples, and I'm actually a renowned expert on software testing also. And I have seen examples after examples where requirements themselves are wrong. And then we just end up having this kind of situation, which is extremely unfortunate. And that's all I can say.
Yeah, no, I agree. I think the feds put into place a whole bunch of requirements. But at the end of the day, it's up to us. Yeah, I don't care what the feds say. It's up to us to make sure that we've adequately tested. Now, that ended up being an interesting example because it was really about workflow. It really wasn't about the software itself. And I agree with you that with meaningful use, where it's basically, for those of you who don't know what that means, the Fed said you have to do such and such. New York State, requires electronic prescribing. And I agree that checking the boxes is a critical part of hospitals being able to function and getting reimbursed. But frankly, at the end of the day, it's still up to us to make sure.
Yeah, you're absolutely right. But I think if you just think about this Boeing example and recent all other examples, requirements having one sensor versus two sensors are really, really critical part of the design. And you can't really blame people who are developing software as a part of it. It's just a matter of requirements which have been really not thought through as carefully. Sorry, I don't mean to.
Oh yeah, no. And also, I agree.
I really am enjoying every second of it.
No, I agree. It's the software engineers were not the problem in the Boeing situation. In fact, they were the ones who blew the whistle that you needed a backup system. I mean, you can't think of any important system that's life and death that doesn't have a backup. And so, again, the software engineers were not the problem here. It was really the higher up. It was also, I mean, as long as we're getting off the beaten trail here, it was the regulators. I mean, the regulators, sort of let Boeing off the hook initially and said they didn't need to test a second intervention. All right, anyway, your point's well taken, and I agree that following, the Fed's requirements is a problem. In medicine, we have this is back to testing. We have a concept which we call equipoise, which is we really don't know in advance if an intervention is going to make things better or worse. I mean, if you know that a drug is going to make someone better, and everybody better, then it's unethical to divide the group in half and not give the drug to the other half. And if you know that it's going to make people worse, obviously, it's unethical. So any research study here conducted at Columbia and every other medical institution demands equipoise. You actually don't know in advance. And I think one of the problems the patients often have is they want to get into a clinical trial without realizing they may end up being harmed by the trial rather than benefiting from the trial. This needs to be a principle of software intervention, which it isn't right now. There needs to be there needs to be a recognition that the intervention may cause more harm than good. And I think, again, the CPOE, the electronic prescribing might be a good example. But it's not in our culture in IT to even think about the downside because we're so enthusiastic about the upside.
Dr. Chase, if I could add something, are we getting to the point where with second opinions, we will be remiss if we don't put it through a Watson or an AI application? And how culturally might that be an issue between, let's say, Europe and the United States, where, okay, who would be more receptive to that or not?
Let me just in other words, it would be unethical to not consult.
Exactly, and using the AI tool to do that. Yeah.
Right. I feel that way when the application has proved that it's of value. So an example, we actually have this app now in our library. It's called Isabel. It has been shown repeatedly in articles published in New England Journal of Medicine that when a physician uses this diagnostic tool, the rate of correct diagnoses go up. So maybe it is unethical to not use that application if I'm caring for my patient. I think when it comes to Watson, I'm not sure. Watson hasn't proved to me that it's as good and reliable as Isabel. So it's sort of, I see it as it's important to establish the utility of the intervention before And then maybe it is, when I talk to friends and family about Isabel and diagnosis, they're appalled that every physician doesn't use Isabel, at least at some point, to make sure they haven't missed the diagnosis. But they are head and shoulders above everybody else, and they have a long line of randomized controlled trials showing that the intervention improves outcome.
Right. Thank you.
Thank you. Yeah, keep interrupting. So my only point here is an obvious one. We need to test the intervention in situ where it's going to be used, and test it on people, clinicians who are not techies. I mean, if you test something on me, I may have a more favorable opinion because I'm a techie. So you need to be able to test these interventions before implementation. So let me then take a giant step forward. And again, maybe this is inappropriate, but maybe there's fraud out there. How do I know what in the AI development world is not fraudulent? Is there fraud out there? Why would I even think that? And I don't know the answer to that easier, but there's clearly fraud in pharma. I mean, there's a whole, again, if I sound overly paranoid, I'm not paranoid because I've lived through all this, and we also teach the students about it. There's a history of fraud in pharma. I think the most well-known is Vioxx, which was the painkiller, the Advil-like painkiller, which caused a 4-fold increase in heart attacks. And the physicians at Merck actually manipulated the patient data. They pulled people out who had heart attacks so that they could publish, they had a more favorable result, and then they published it in the New England Journal of Medicine. It was a catastrophe. I mean, maybe that's not the definition of fraud, but certainly pulling out, manipulating the data is. So pharma does not have a great history here. I mean, there are dozens of examples. Baycol is a drug that you use for cholesterol. 50 people died that the company was aware of before they pulled the drug from the market. And on a sort of less sensational level, we've got all these Alzheimer's drugs that we give for patients that have no therapeutic benefit. It's been known for years they have no therapeutic benefit. And it also puts patients at risk for sudden death because they have a potential for a life-threatening adverse event. Those drugs are still on the market. They still increase the propensity to have fatal cardiac arrhythmias. So you're shaped by your past experiences. My appreciation of the potential for fraud in pharma has made me ask the same questions about AI. And I will make a distinction later on between commercial AI and academic AI. So do we trust the developers, the implementers to do no harm? Not really, because it's, there might be reasons why they just go forge ahead and implement things. Certainly we've implemented things here in RNYP EHR that was not fully vetted and trusted because it just seemed like a good idea. Fortunately, those did not result in harm. There's a whole institute at Penn that studies harm as a result of technology and interventions. Justice. AI should benefit all patients regardless of financial means. Well, that will happen if the intervention or the AI is embedded in the electronic health record. Anybody coming to New York Presbyterian will benefit from an AI intervention if it's in the electronic health record, regardless of their status. But that's not true out in the rest of the world. For the commercial aspects of AI marketed to consumers will, almost by definition, discriminate against those who can afford the application and are digitally competent. It's a separate issue, which I'm not going to talk about. So I was looking for an example of this, and I found Noom. There were like 47 ads on Noom when I was watching TV the other night. And it actually was very intriguing. It was clearly AI. It said, find out what's possible with Noom's psychology-based evaluation. So obviously, you're going to put in information about yourself, and then the machine's going to crunch the numbers and come up with a weight loss plan just for you. What you're going to have to answer personal questions. Maybe you eat when you're aggravated, like your in-laws come over and you're aggravated, so you overeat. There are all sorts of reasons why people don't stick to a diet. So I thought, this is great. I went in, logged in, and basically, 90% no surprise. This is not a free app. You have a 14-day free trial offer. Here's how it works. But it's going to cost you $20 a month. And the punchline is that people who can afford this are going to be able to lose weight, hopefully. And people who can't afford it and who need to lose weight are not going to be able to benefit. I think, you know, this may be the best on the market, and there are a lot of weight loss apps. So by definition, commercial AI is not going to adhere to a commitment to justice. Respect for autonomy, and this one I haven't figured out what the answer is. Patients are not going to be autonomous, have autonomy if a machine is telling you what to do. And I'm not sure clinicians are going to have autonomy if AI is prescriptive. And that gets, of course, raises the question is what do medical students or physicians have to know about AI in order to just not blindly follow the recommendations and possibly do something harmful. So on one hand, the black box is impenetrable. There's no autonomy when AI prescribes a course of action. If that prompt in the intensive care unit says, give vasopressin now, I'm not in a position, none of those people, even the specialists, are in a position to say, well, hold on a second. Let me see how the AI came up with that. They're just going to have to act. It gets us back to the question asked before. It might be unethical to not follow that recommendation. And this is going to be especially true as we enter the era of precision medicine, where we have all the genetic information. And the only thing we can rely on is on proven value. That if the intervention has proved to me as clinician that the outcome is better using the intervention rather than worse, then I'm going to rely on it. I have to, like every other test. It's if I do a test for HIV or I do a test for colon cancer, I look at the value of the predictive value of the test, and then if it's insufficient, I don't use it, and if it's sufficient, I take it into my decision making. So the black box will be impenetrable, but I'm not sure it matters. It doesn't matter if we know what went into all that machine learning. It only matters if the machine's value can be proved by conventional methods. And then beneficence, is AI going to undermine my ability to benefit the patient? This is, again, I'm not really sure where this is going and how to think about it, but I'm concerned that my best intention is to help the patient. And I'm going to use AI because I think it's proved to me that's of value. And is that at risk? So I think about hypertension. That's the bread and butter of medical practice across the world. I'm a kidney doctor. It's the bread and butter of the kidney doctor's practice. The treatment of hypertension. And I found this article, actually I just realized it. Andrew Bombach is on our staff here. It's amazing that. And they have a artificial intelligence paradigm to predict and manage hypertension. It's actually pretty good. So that's very important. And we go back to the decision tree. I can't analyze that tree, especially with all those other drugs. I'm going to look for a machine learning algorithm that is going to help me figure out what the best drug is. And so the machine may say, look, based on everything I know, choose drug 2. And my problem, again, I don't think this is unnecessarily or overly paranoid, is how do I know that the algorithm wasn't rigged to choose that drug? And you think that is out of the realm of possibility? Absolutely not. There's no question in my mind. You just have to read the paper, look at pharma as as an example. There's no question in my mind that the potential for modifying the algorithm, even if it's subtle, Google gives money to some academic in order to foster research. Pharma gives money to develop a paradigm for drug choice. There's no way that this won't be influenced if there's not mindfulness and full disclosure. So I'm worried about that, and I'm not sure what to think. I mean, right now we're still living in an era where pharma has pushed the drugs for hypercholesterolemia so dramatically that 95-year-old people are taking the drug when they don't need it because they live to be 95, and obviously the cholesterol is not a problem. This will seep its way, this force will seep its way into the paradigms, and I'm not sure how, and I just need to be vigilant. So are there ethical principles that should guide the development and implementation? Yeah, basically non-malfeasance, ensure adequate testing, root out fraud, justice. Maybe the insurers will pay for Noom or whatever it's called. Maybe CMS will pay for it. If Noom is as good as it says and it ends up reducing the incidence of severe obesity in this country, then maybe CMS will pay for it, and that will be a huge benefit to the patient. When it comes to autonomy, as mentioned, I don't think we can be autonomous, that we can figure out what's in the black box and be purely autonomous. We need proven value. And we may need a group of people like Cochrane reviewers of drugs to review, maybe that's already happening and I just haven't stumbled upon it yet. We need a group of deep thinkers to look at each intervention before it goes live in a hospital and say, prove it to me. See, scientists, in general, don't believe anything. You have to prove to them that something works. Prove it to me using the typical analysis that we're all dependent upon, and then we'll put it in place. And then the physicians can use it autonomously. On their phone it says, do this. And they say, fine, it's been vetted by the higher ups, I'm going to use it. And lastly, beneficence. I don't know what's going to happen when money starts seeping into commercial AI. There's got to be full disclosure. You publish an article in the New England Journal of Medicine. If you're getting money from Merck, that's apparent. Or even that's become difficult for a reader to figure out. Now, New England Journal of Medicine makes you go to another PDF so you can figure out the person who wrote the article owns stock in the company. So full disclosure is mandatory. I don't think we see that in AI. And the model here is pharma, skeptical, don't be the first medical center on the block to adopt, independent watchdog groups to assess before implementation, and don't be fooled by the hype. The hype is unbelievable in the AI space, and it's seductive, but most of it hasn't been proved to be valuable. And we need federal oversight, but the FDA is completely clueless through no fault of their own. They can't possibly keep up with all I think, there are dozens of AI interventions that are being developed, and the FDA can't keep up with that, and I'm not sure they're the right body anyway. So I want to end with what I see as, I only kind of thought the last couple of days, that I really do see two different routes to AI. There's academic development, and then there's corporate development, and have different codes of ethics. Academic development in developing AI is clearly to benefit the patient, and because they're under they're in the building of physicians who adhere to the ethical code, they are guided by the same principles. The benefit of the patient, the ethical principles, and they're self-monitoring. Medicine is a profession, and by definition, we monitor ourselves. We try to get rid of the bad apples and do what's right for the patient. Corporate development, I think, is a completely different can of worms. It's for the benefit of the shareholders and venture capital investments. They're not obligated by ethical concern. They're only obligated and worried about financial risk. Every time I gave a talk at IBM on Watson, the hands would go up and they go, are we going to get sued if we come up with the wrong recommendation? It's not that they wanted to harm patients, hardly, but their first thought was, are we going to get sued? And the risk to the industry is a greater worry than, I think, harming the patient. I mean, maybe I'm doing disservice to the whole group, but so be it. And the FDA can't serve this purpose. And lastly, to be a completely negative view, healthcare is a lucrative space to invest in. I mean, why did they choose healthcare, the startups? Because several $1 trillion of the US budget is given to healthcare. So there are hundreds of startups in the healthcare space, corporate, and basically they chose healthcare because it's just a great place to make money if you come up with the right app. I will say I do, as I mentioned, I consult for startups, and on numerous occasions, they give me a pitch that is a great idea. And I think, wow, this is such a good idea. I really hope they could pull this off. And then I go, show me the results of the intervention, and they have literally no results. They have venture capital, they've raised $1 million here. They literally have no results. And I'm sure you're all aware of the Elizabeth Holmes story and Theranos. It's not dissimilar. It's like, let's make money in healthcare, and we have an idea, but we have no idea of how to accomplish that. Again, this could be an overly negative view, but so be it. So at this point, where are we now? The physician and the patient has this intermeddler here that they need, the computer. And the best that we can do right now, the machine will provide the best up-to-date vetted information to clinician, maybe help in decision-making. It's got to be vetted. It's got to be proved to be useful. And the clinician then discusses the recommendations with the patient and to agree to a course of action. And hopefully down the road, this box over here will just bigger and bigger. And if the intensive care unit, the machine will have better ideas for how to proceed, but we're not there yet. I think we've accomplished our learning objectives. I hope we certainly did. We need AI in the medical practice because we're not doing so well. We have a couple of examples that are success stories. We have several shortcomings that we need to think about. And I'm not sure that we can trust AI right now in medicine, certainly not the ones that are out in the commercial space. I'd like to thank you, and I'm open for questions.
Professor, I have a quick question regarding the justice issue. So in terms of trends in technology, I was thinking of education where 10 years ago, fancy private schools were touting the integration of iPads in their classrooms, and it was this novel complement to in-person instruction. And today we see a reversal where low resource schools are using tech to replace in-person instructors increasingly, and private schools are touting the device-free learning experience where only professors are giving one-on-one instruction, et cetera. I was just curious if you foresee in the future the AI clinical encounter being relegated to Medicaid populations, et cetera, and a premium being placed on the in-person consultation.
It's a good question. I like the idea of revisiting the iPad, its pros and cons, and also not necessarily paying homage to how does a device change the way you think about things. A lot of us feel that with the right amount of vetted AI, it actually probably will free us to spend more time with the patient, to get a better history and a better physical and find out who they are, instead of, this harkens back to the comment about being the guidelines from the feds making us click the boxes. Right now, we get sidetracked with all the little tasks that we need to accomplish on the computer. So theoretically, if the machine is operating in the background, it may free us, and we get away from spending time over the electronic health record and more time with our patient.
Right.
It's still up in the air. It's still open a question in my mind exactly how we're going to get to that point. But I think that is something to think about. It's interesting you talk about devices. There was a study that my colleague Vimla Patel did here years ago, where she showed that when a physician wrote out the narrative of the patient on a piece of paper, it had sort of a beginning, middle, and end, and had a point to it and a conclusion. Then for the next group of patients, when they wrote the same narrative on an electronic health record, the more they did, the more degraded the narrative came. It just became sort of a series of bullets. There was really no beginning, middle, or end, and it was actually pretty poorly written. And then when the third stage was, the physicians went back to the narrative, the written narrative, and the written narrative was equally poor, having spent time on the electronic health record. So it sort of gets back to your iPad comment. One thing that I think we've considered is the influence of an artifact, electronic device, on the way we think about things. And at its worst, it distracts us from our patients. And maybe down the road, it will free us to spend more time. I'm not sure I answered your question, but it was very provocative.
That was great. Thank you.
Thank you.
I had a question too. The slide before where you talk about corporate development, can you be more specific who, like the type of companies you're referring to? Because I think some of the tech, I mean, are you just referring to tech companies, or like what is in that box of corporate development? Because a lot of this like AI development is being done in partnership with some academic institutions. So I just want to be sure.
No, it's a good question. I should have had a line connecting the two, and I will do that. That is certainly, if you look at, again, the pharma example, many scientists either left academia to start their own companies, or they consult with companies. And that I think presents a serious conflict of interest. I mean, I don't think that you can manage your conflict when you're a scientist and you're on the board. I mean, there's a way to be on the board and have no say over any of the drugs, or you can do it voluntarily. I'm a volunteer for the board to give them advice. But once you own stock in the company, it conflicts you, and there's no way around that. So I'm glad you asked that question, because it does show that there are different levels of engagement.
Yeah, well, I mean, I understand with the stock in the company, but if, you know, Carla just asked too, like where there's these sort of public-private industry collaborations that are working together on these efforts, you know, does that change? And when there's like an actual public, like partnership with a company that's public, because I do think, like, you know, I'm in pharma and we do a lot of work with academic institutions to develop algorithms and AI, and, you know, we work with Stanford and USC, you know, with very reputable institutions. So I want to just be sure I understand.
Yeah, I think pharma can do, that's perfectly appropriate for pharma. And it's perfectly appropriate for an AI developer to use as much as they can from academia to better their product. A pharma's main responsibility is to their shareholders and to develop products that are going to be useful. They are worried about side effects. So I think that's not what the conflict is in my mind. I'm not sure about the people who consult for pharma on the academic side. What are they getting out of it? Often they end up getting conflicted. I understand pharma, for example, has to do randomized controlled studies at institutions. They hook up with somebody, pay them for it, and that academic obviously is conflicted. So I think maybe I'd like to make a distinction here, the more I've thought about it, is that pharma's business model, I think it's appropriate for them to use academia as best they can and find the best sort of cutting edge algorithms. And I guess use is the right word, engage as many scientists as possible to push their product. Certainly IBM does that. IBM hooks up with people in my department all the time. But then they take all the algorithms and they use it for their own purposes. I mean, there's nothing wrong with that. We're here for the science. I'm not sure I completely answer your question, but it's a really interesting point.
I just think it's more complicated.
Absolutely. No, I did simplify matters, but I do think, I think that pharma has benefited from the class action lawsuits that's basically made pharma. Actually, pharma is a leader in looking for drug interactions and drug adverse events. Having been a follower, not really, spending that much time looking for adverse events. Whatever the motivation is, it's fine with me if it ends up that it's because they don't want to get sued. So they've got a much more sophisticated, I think, ethical view, whereas they're going to do the right thing for them, sort of an Adam Smithy kind of view. They're going to do the right thing for them because it's also going to, and it will also do the right thing for the patients. I'm not sure AI has gotten to that level yet. And admittedly, it was an extreme position, but that's how I think.
Dr. Chase, I don't know if
Yes.
this is in your remit at New York Press, but in a big research-driven hospital as yours is, there will be AI applications being developed internally. There'll be AI applications and machine learning applications being purchased from commercial vendors, as you pointed out. And is there yet an internal process that brings together physician bioinformatics specialists, people from a variety of departments? Is there a vetting system yet?
Yes, there is. There's a committee, for example, that looks at drug-drug interactions. I mean, that's one of the sort of earliest interventions. Again, it's not really AI, but the problem with the drug-drug interaction system is that the physicians ignore the prompts because they get so many of them.
Yeah.
Why can't you give someone who's on one blood thinner aspirin if they have a headache? So there's a committee that actually looks over those drug-drug interactions tables. Just as an aside, there are probably 50 different tables. And we bought our table from a vendor that was vetted by our clinicians, and it ends up being different from the list that they use at Micromedics and the list they use at all these other places. Just giving you an idea of the complexity here. But the answer is yes, there is a group that, but in terms of implementing sophisticated AI, we're not there yet. We haven't really implemented any sophisticated AI like the intensive care decision machine. As far as I know, that's not here implemented, and maybe it's being tested out, or maybe nobody even knows about it. So there are groups. We do have a watchdog group here.
Thank you. Do we have any other questions? If not, I'm going to thank Dr. Chase very much. What I think was a very compelling overview that raises many of the issues that we've been touching on in our reading and introduced us to some new issues to think about. And of course, Dr. Chase is at Columbia
Email me.
Sorry?
You can email me
Yes.
if you have further questions. I thought the questions were terrific. Thank you.
So thank you. That's very generous. And very much appreciated having you here. And we're glad to be your first Zoom experience.
Thank you.
In our pre-class discussion, we were talking about how we all may be doing all our teaching on Zoom for a little while now as the COVID-19 pandemic spread. So we have some extra time, and I am going to, as I said, go over about 5 slides myself, mostly class business, but a couple of comments that are relevant to what we've seen here. Christy?
Yeah, you can zone, you can.
I'd like to share my own screen.
I'd like to thank Dr. Chase, excuse me, I'd like to thank Dr. Chase also for a wonderful presentation. And just announce to the class that we're going to go deeper next week into bias, which Dr. Chase introduced us to in this lecture. And I want to thank you for that, Dr. Chase.
Thank you. Thank you for your comments. It's fun being in fun. I'm not sure that's the right term. Fascinating being in a field that is in the midst of growing, exploding, tremendous potential, all sorts of forces that can make it be, really life-saving, but also being concerned about what are the ethical issues and what do the feds need to do, and what do we need to do as institutions? It's exciting. I'm glad I survived this long to live through this.
Yeah.
Thank you.
Thank you again.
All right,
Christy, are you seeing, is everyone seeing my screen?
Yes.
Okay, good. So I'm going to start backwards here because we've been talking about the physician role. So I hope you're going to consolidate your thinking about this, because this is something that we're going to emphasize, the physician-patient relationship and AI. So the traditional physician role you're familiar with. There are technical and professional competences, diagnosis, prognosis, coming up with treatment plans that could use robust clinical decision support based on good data and then sound AI algorithms. They're interprofessional relationships. So doctors obviously are a node of support and of consultation for other professionals, and doctors, since medicine is still quite hierarchical, set the tasks for other professionals, and physicians take care of us in a much more global way. They take care of us as patients and families. It's that personal relationship with physicians that often is the most important part of our patient experience or of a family's experience. As our medical environment becomes more AI enriched, we may see a kind of splitting up of the physician role. So we may see the kind of super clinician who is augmented by AI tools and decision and predictive tools. We may see that some physicians focus more on the relational content of the physician-patient relationship. There's some of that certainly now in medicine, but we may see this more extreme versions of this. And so what physicians will get is more support for cognitive tasks, allowing them to split off in these ways. And I can't see on my screen here. Yes, thank you. Just moving to the side. And the bioinformatics specialist should be very important in driving adoption of AI, in setting standards, and in supporting other physicians and supporting the whole institution. So if you're interested in the physician role, then you might start to think in this way. And now I'll go to the beginning of my slides. So that was a wonderful talk from Dr. Chase, and the Columbia Bioinformatics Division of the medical center is very sophisticated and a great resource. You know that the final paper abstract is due for submission on March 6th. That's 2 days from now. And then the peer response section of that is due on March 8th. Both of them are due at 11:59. So just reminding you of that. This is not a terribly formal abstract. It's 100 to 200 words. You're not committed to this topic, but of course we want to get you going on the final paper. One strategy for you is certainly to look out ahead at the other topics that we will be covering. There'll be a couple of readings added to my modules because the field is so in flux, and great new articles, updated articles are coming to the fore every day. So I decided to change out a couple of things. I'm also going to talk to you about a few additional paper topics here. These are not in order of importance. Some of them are drilled down topics, some of them are more general, and I'm not going to go through each of them in detail. You will recognize whether you bring background to this or interest in any of these. And of course, please feel free to write to any of us, to Professor Dalal, to Professor Silverman, or to me about a topic that you're considering, and we'll be happy to bring our resources and advice to bear for you. And I've appreciated speaking with a couple of you about topics that you're considering. So if you are interested in the mechanics of system architecture and in AI implementations in a fairly granular way, you can think about the ethics, comparative ethics, and the comparative policy concerns of contrasting AI systems. So structured versus unstructured learning, and what the requirements are, the ethical and policy requirements are for implementing those kinds of systems with integrity and how they vary, expert systems versus machine learning. On a completely different tack, you can think about affective AI. Affective AI is AI that reads emotions, and also I think a good quality definition of affective AI is that it provokes emotions as well. So you can think about interfaces in the clinical encounter where a patient is in contact with a machine, a device of some sort, an applications interface, and that, sorry. Too many devices, too little time. So we will find this in clinical medicine, and remember that we anthropomorphize objects, we anthropomorphize systems, And is this really something that we want to encourage in healthcare? What are the implications of that? Consumer-facing health apps, a very rich subject. So consent in the use of consumer-facing health apps like the NUM diet app, and also data sharing in those applications is not sharing. Many of these health-related apps are sending lots of data to lots of commercial actors in the field. Certainly, lots of healthcare apps are sending, and sites are sending data to Google, and so that ads that you see are as relevant as possible. You could certainly think about data ownership, custody, and data benefit. So remember that data is valuable in the aggregate. A single data point doesn't count for very much. Data is value in the aggregate. So who's going to extract value from that data? That's a very general topic, but you can think about patient activism. So patients are banding together who have a disease in common or a condition in common. This has gone on for a long time in healthcare for support or in support for emotional support or in support of research or to exchange information. But now patients are thinking, patient activist groups are thinking about pooling their data and trying to leverage that in ways that benefit them, benefit the healthcare system, and benefit future patients who may have the same kind of condition or the same disease. The ethics of data quality, terribly important. You will notice in the reading, you may have noticed in the Watson reading, that there were gold standard labels that physicians were engaged in applying to healthcare data. So data doesn't explain itself. Data doesn't create its own integrity. Big databases that are used for real world evidence all are processed initially by human beings, by educated human beings who take messy data and regularize it, look after its quality, and then that data, which is human curated, becomes the basis for good training set data. And there are ethical questions about this and policy questions that you can think through. Very happy to discuss this with you. You can think about your organization as a case study. So if you work in healthcare, if you work in pharma, you can do a bit of research on how your own organization is approaching AI, either making AI enriched products, making decision support products, and the ethics of how you're doing that, or if you're adopting them. And of course, within the strictures of the organization that you're working in, but that's a great approach for a paper. This is a very—
Stephanie, I think Carla has a question about organizational
okay.
AI. I don't know if you saw
Carla.
that or not.
Hi, and it builds a little bit on what Missy was talking about, but maybe this is a paper topic. The inherent structure of an organization, I think it's often conflated that just because it's a for-profit entity or an entity that's not an academic center is somehow fraught with fraud and ethical conflicts. And I think that's an interesting distinction and one we've been wrestling with, like just because it's a commercial entity, is the use somehow inappropriate a priori? And Missy did a nice job of asking the question, and I couldn't come up with it very well in the moment, but I think, and again, maybe it's just a paper topic, but I think that's an interesting conundrum, that just because an organization happens to be structured a particular way, what they're doing is inherently fraught, and is it actually the use of the data or what we're talking about that is really important to focus on, as opposed, and there could be factors about the organization, but just something to comment more than a question probably.
Yeah, no, I think that is a very rich topic. And for those of you who are in pharma, I know that it's not easy to be in pharma. Often less appreciated than probably should be, and there's focus on problems in pharma which are very real, including fraud, as we all know, but that doesn't encompass the entire universe of what pharma offers to us. So yes, you can certainly think about that, but if the foundational concern is what are the incentives for an organization. So a healthcare organization, in theory, is incentivized to provide the best possible care that it can for patients for patients and their family. A for-profit organization, in theory, offers a good quality service or product, and as part of that, then it makes a profit, it flourishes in the market, and so forth. However, incentives can become perverse, and so instead of offering a best quality product or service, focuses purely on the bottom line, and then we get into all kinds of trouble. Now, this is a great topic to think about here, where, as Dr. Chase was saying, healthcare has interestingly lagged in implementing AI, while the interest in the ethics of AI in other fields has really blossomed over the last, I would say, 5 to 7 years. Started maybe 25 years ago, but it was really a specialist topic. So healthcare can build on existing work that has been done in the ethical and policy and social implications of AI in other domains. And it's just a very good time to be getting in on the semi-ground floor, maybe on the second floor, of questions about health, motivation, the relationship between commerce and market forces in AI and healthcare, and non-market forces and non-market actors. So that wasn't really much of an answer. You offered a comment. That was sort of comment in return. Let's look at this item on health and disability insurance. So you know that you are creating clouds of data, and they are useful and repurposed in a variety of ways that you may not initially have thought of. That includes something like this. A commercial firm was offering a voice analysis program, and it claimed to be able to find reliable signs in people's voices that they had early stage Parkinson's or early stage Alzheimer's. Now, who would use something like this? Well, if you are having a chat over the phone with a sales agent about disability insurance, that would be a place where this app could intervene. And in fact, that happened. You could think about the ethics of that, about informed consent, about reliability, about how these apps are marketed, about how carefully an insurer vets these before they use them, et cetera, et cetera. If you come from the philosophy side, you can think about epistemology. That's how we know what we know, how we accumulate knowledge, ethics, and unsupervised learning in research or clinical medicine. This is a very rich and slightly technical topic in philosophy. If you're interested in this, some of my work revolves around this now, and I would be happy to discuss this with you. Certainly the ethics of continuous healthcare surveillance. So how are we surveilled in terms of our health status, population health status, individual health status? So there's lots of information to be gotten out of our typing style. Are we developing, again, Parkinson's? Our food purchase habits, our geolocation data, certainly our economic status, which is indicated by all sorts of data that you're generating, not just what's on your tax forms, et cetera. So the ethics of continuous surveillance, and the inadequacies, possibly, of current protections. You know, HIPAA is a very limited set of protections in a very specific environment. Then Dr. Chase was, I think, touching on something that circles around this final point here, the right to an AI diagnosis or treatment plan. So Michael mentioned that there could be a sorting out in the healthcare environment, so that if you want to see a doctor, it's privileged patients who have a bit more money who get to see an actual physician, and the rest of us are left going to the AI, a bit like going to the ATM instead of going to the teller in the bank, although who wants to spend time with the teller these days, or for a long time. We could flip this on its head. Suppose you're from a group, or you're a person who feels that you are not getting adequate attention from a physician, and you think that an AI would give a more objective, more dispassionate, more fact, more evidence-based diagnosis or treatment plan to you. Should you be able to request that? Doctors will want, when they partner with AI decision supports, to have the final say. So those are just some further topics that you could think about. Again, some general and some less general. We're going to talk about this week's resources just briefly. So not for the primary thrust or not for the primary themes of the resources, but some things I'd like you to pay attention to or know. You read the very dense Eric Topol article this week. It is one of, I would say, 40 important articles that are quite similar, that are written by physicians to try to explain the new AI environment, mostly to other physicians. There are lots of good jumping off points for papers in there, and I think it's a good resource for you to have if you want to do further work on ethics, policy, and AI, because it's very information rich and dense. However, you would also want to know that last year he published a book titled Deep Medicine: How Artificial Intelligence Can Make Healthcare Human Again. It really is a doctor's manifesto that physicians should be in charge of how AI is implemented in healthcare because, and here comes the moral rationale, because of physicians' commitment to beneficence and respect for other principles in healthcare that make for best possible patient outcomes, including respect, justice, non-maleficence, and so forth. And what you want to keep in mind in many of these readings, and something that Dr. Chase also obviously is concerned with, is that decision support systems, prognostic systems, and so forth, many of them will be commercial systems. They'll be bought off the shelf. So how are those going to be validated? And AI systems are different because they may be dynamic learners that are modifying themselves while we're using them, unlike pharma. Approved drugs don't change on the shelf. And so there needs to be a similarly dynamic method of supervision, of auditing, of post-marketing testing, if you want to use borrow something from pharma there. So that was the Topol. The Strickland was the article for the IEEE about Watson. I thought it was interesting that this was published in the IEEE is maybe the largest professional organization in the world, and they bring us software engineers, hardware engineers. They are the folks who bring us modern life as it's expressed in laptops, phones, the internet, and many other things. So the thinking of the publishers here was in that general interest publication, the IEEE's Spectrum magazine, that that audience would be interested in a kind of autopsy of the Watson experience. The IEEE publishes a number of peer-reviewed academic journals, but they thought that engineers on their time off, when they're keeping up with things of interest to engineers, would want to be reading that, and I think that's right. Notice that Watson was marketed, and its ambition is to be broadly competent decision platform. So it really would be your home in healthcare. It turns out it was a bit over-ambitious. I don't think we have explained this term to you, NLP, that's natural language processing. If you're not familiar with it, imagine more sophisticated version of OCR scanning of handwriting. So converting unstructured data, generally text, into some kind of more structured data that can then be used for machine learning and AI applications. I'm going to skip this last point. Because we're going to make more of that in another lecture. Finally, the Moorfields DeepMind readings that you did, I put those in there, one, because this is a nice example of success in an AI application. It's a good contrast with the Watson experience. So it was much less ambitious, much more narrow, much more focused on embedding itself well in the NHS environment. So this happens to have been, as you read, a UK application that was co-sponsored with the National Health Service. And it's designed specifically for the primary care level so that a physician who doesn't have special training can use the scanning application and then triage patients to specialty care or not. So it's to increase efficiency as well as to make sure that patients who may have a serious eye condition are seen more quickly. So I hope you enjoyed all these reading. Again, the topo was very dense, but it's if you're interested in the field, that's a good core reading to keep in mind. And I think that'll be a good reading for a couple of years, even in a very fast moving field. I wanted you just to know about this. In May, there's a webinar at the New York Academy of Sciences. It's just online and it's computational approaches to clinical medicine, as you can see. And the New York Academy of Sciences is a tremendous resource for emerging technologies. Some things are very specific, some things are more general and have more social and policy implications. I'm recommending this one to you because it doesn't cost anything. You don't have to be a member. I think it's free for all. And it's online, so convenient for everyone as well. So that's it for this week. Next week, we will be privileged to hear Professor Silverman's first module. I'm really looking forward to that. And if you, again, please pay attention to the fact that we have deadlines coming up on the 6th and the 8th. Jared, do you want to say anything about next week?
I've already introduced myself about next week's topic, and I'm again thankful for Dr. Chase on the wonderful presentation today, and actually a little introduction to bias. So that was a good lead for me, and I'm sure the course. So, and thank you, Stephanie, for your slides. And I'm going to be referring to Topol as well in my lecture because in deep medicine, you know, he gets into bias in great detail. So I'll be going there as well. So
Good.
Everyone have a great week, and we'll see you next Wednesday.
Okay.
All
Good
right.
night, guys.
Bye-bye.